Right, we've got everyone joining. So good day, everyone. My name is Dominic Alain, and I'm the director for the Global Health Program here in the Faculty of Medicine. It's my great pleasure to introduce Dr. Lena Roa, who's joining us today. Dr. Roa is a Paul Farmer Research Fellow in Global Surgery at the Department of Global Health and Social Medicine at Harvard Medical School. And she's a resident in our own program here, Obstetrics and Gynecology at the U of A. And her research focuses on inequities around access to healthcare, particularly to high quality and affordable surgical care. She currently works in Amazonas, Brazil, and Chiapas, Mexico, building research capacity and improving quality of surgical care. She's passionate about maternal health, particularly access to cesarean sections and medical education. And in the past, she obtained her medical degree from the University of Toronto, and she has an MPH in clinical effectiveness from the Harvard School of Public Health. And today, Dr. Roa is going to talk to us about achieving equitable access to high quality obstetrics, surgical, and anesthesia care. So we're very happy to have her and looking forward to her talk. Dr. Roa, the floor is yours.
Perfect. Thank you very much for the introduction. So today I am going to be talking about what the field of global surgery is within the context of global health, and specifically how does it relate to obstetric care and the surgical care of women. And obviously we can never talk about surgery without talking about anesthesia. Those go hand in hand. And so my objectives for this talk are first to define what global surgery is, and then review some trends of global maternal mortality and how that relates to surgical care. Then I'm just going to review the 5 key messages and recommendations from the Lancet Commission on Global Surgery, as this is the document that laid the ground for the academic field of global surgery. And then finally, I'm going to focus a little bit on what is high quality surgical care, and review some of the frameworks and give some examples from my research on how we can try to measure quality of surgical care. So I'm going to get started on the definitions and maternal mortality. And if anybody has any questions at any point, feel free to interrupt and ask questions either throughout the presentation or at the end. So there's many definitions for what global surgery is. I think everybody here probably is familiar with what global health is, but this is one of the most commonly used definitions. So it's a field in global health that combines research, practice, policy, as well as advocacy to promote access to safe and quality surgical care. And we'll talk about what that means. It focuses on health outcomes and as well as equity. And it tries to combine population-based approaches with individual level clinical care. So when we think of surgery, we often think about the patient in the operating room. But what global surgery does is it tries to combine it with public health and population-based approaches. It's also meant to incorporate all surgical specialties. So it's not about just general surgery or trauma. It's about all the surgical specialties. This obviously includes anesthesia, perioperative care, and anybody who is in contact with surgical patients. So this is rehabilitation, palliative care, neonatology, so a lot of the medical specialties. And obviously it also includes our allied health professionals, because they do a lot of the heavy lifting when caring for surgical patients. It does have a social justice lens, and it does focus on the care of underserved populations, and it's meant to be for all countries. So not just in low and middle income countries, but everywhere. And then finally, it emphasizes transnational issues, social determinants of health, and solutions. So it tries to move beyond just measuring the problems and trying to implement solutions. But I think it also recognizes that the determinants of inadequate or inequitable surgical care are the result from the current global structures and processes. So it's important to always understand that global political context, even when we're thinking about surgery. So I'm guessing everybody in this audience is familiar with the Sustainable Development Goals. Briefly, how it very directly relates to obstetrical care, so care of women in pregnancy. So it's SDG 3, target 3.1 is to reduce global maternal mortality to less than 70 per 100,000. And this is measured with the maternal mortality ratio, as well as the proportion of births attended by skilled health personnel. I think one of the problems with this definition is that as skilled health personnel, it's usually somebody that can do a vaginal delivery. So around the globe, most vaginal births are attended by midwives. It doesn't take into account that a large portion of women will require a cesarean section, and that requires specialized surgeons as well as anesthesiologists. And then the second target of the SDGs is 3.2, which is to end all preventable deaths under 5 years of age. And most specific to us is the neonatal mortality rate, because we know a large proportion of neonatal deaths are related to timely obstetrical care. So maternal mortality, it's a very good indicator that unfortunately reflects global health inequities. So here you can see the distribution of maternal mortality. And just to put it into context, in Canada, approximately 10 women die for every 100,000 women that are pregnant, compared with places like South Sudan, where this number can be as high as 1,500. So again, to put it a bit into context, if you are a woman in a high-income country that's pregnant, the risk of dying, it's as low as 1 in 3,000. However, if you're in a low-income country, this could be as high as 1 in 40 women dying. So if you take a year in the last couple of years, usually there's approximately 130 million births worldwide, and approximately 300,000 maternal deaths. So this means that every 3 minutes, there is one woman that is dying from a complication of childbirth. In terms of babies, there's approximately 2.6 million stillbirths a year, and approximately 2.7 million neonatal deaths. So that's like 5 million in total when you put those together. And we know that more than 90% of these deaths are preventable. And we know that because we do prevent them in high resource settings. And unfortunately, we know that both maternal and neonatal mortality, 99%, it's occurring in low resource settings. So again, with investment in good surgical systems, this could be prevented. When we look at what causes maternal and neonatal mortality, number one cause is hemorrhage. And for those of you with clinical background, you might remember that the definitive management of severe hemorrhage is with surgery. And then when you look at causes of childhood mortality under 5, 45% is related to neonatal. And not all, but many of them are related to the events that happen around birth. So having highly skilled obstetric and anesthesia care, it's going to be critical to decrease that under 5 mortality. When we look at maternal mortality, often it is talked as a bit of a success story in global health, in that it has come down significantly. So in the last 20 years, it dropped by about 40%. So this shows maternal mortality by continent or by area of the world. So yellow, you have sub-Saharan Africa, and the orange line here, it's the target for the Sustainable Development Goals. And as you can see, there's been improvement pretty much in every region of the world. But towards the end, and this is before COVID, after COVID, I think things are going to be looking much worse, unfortunately. But the maternal mortality starts plateauing. I think part of the reason is, as a global health community, there's been significant improvements in getting women to deliver at hospitals. So I think a lot of this decrease in mortality is due to safe vaginal deliveries. However, to completely drop the maternal mortality, we need to go the extra mile and provide surgical care in the form of C-sections. So now that we've reviewed what global surgery is and how it relates to maternal mortality and obstetric care, I just want to briefly talk about the Lancet Commission on Global Surgery. So global surgery hadn't been very present in the global health community. But as early as 1980, one of the World Health Organization's Director Generals, Dr. Halfdan Mahler, mentioned that it's the vast majority of the population has no access to skilled surgical care, and little was being done to find a solution. And he associates this with social inequities in healthcare. So this is back in the 1980s. Not much was done in an organized, cohesive global effort. There's always been a lot of individual surgical missions that try to address this problem, but there have been very few coordinated efforts. And then in 2008, in the world of academia, Dr. Paul Farmer and Dr. Jim Kim, who are infectious diseases leaders in global health, published a paper in which they called surgery the neglected stepchild of global health. And so pretty much what they argue is there's been progress in infectious diseases, in diarrheal diseases. So lots of kids are surviving, lots of people are surviving these diseases, to then go on and die of a car accident because of lack of access to trauma care, or to die during childbirth because of lack of access to a C-section. So it's a big call of action to the surgeons to get more involved in global health in a coordinated way, like many of our colleagues in pediatrics and infectious diseases had done. 2015 was a big year for the field of global surgery. So these were 3 key publications. The first one is by the World Bank, in which they made an economic argument that investing in surgery was cost effective. The second one is the Lancet Commission in Global Surgery, and I will go in more detail about this document. And then the third one is from the World Health Assembly. All the WHO members signed this resolution committing to strengthen emergency surgical and anesthesia care. So again, like I said, I'm going to talk a little bit more about this Lancet Commission. So they came up with 5 key messages. The first message is that they estimated the number of people that currently lack access to safe and affordable surgical care. So approximately 5 out of the 7 people lack this care. And we know it's not just any 5 people. We know it's mostly the elderly, children, women, and those in low-risk settings. And the way this was calculated is they looked at the number of population that did not have timely care, because surgery, it is time dependent, did not have access to a facility that could provide this, that has the capacity to provide surgery. Surgery had to be safe, because there's no point in having surgery if you're going to end up with more complications and comorbidities. And it also had to be affordable. And I think affordable is a big piece of surgery, because traditionally surgical interventions have been considered quite expensive. So once you looked at all of this, that's how that 5 billion people was calculated. The second key message from this commission was that 143 million additional surgical procedures are needed in low and middle income countries every year. And so this was estimated in order to address the current burden of surgical disease. And we know that they're not needed in all the countries. We know that currently the poorest 1/3 of the world's population is only receiving 6% of the surgical procedures. So again, this is a call for the investment of surgical care to focus on the world's poorest populations. And then going back to the aspect about financial risk protection. So it was estimated on this Lancet Commission that 81 million people face catastrophic expenditures when they have to pay for surgery and anesthesia. Of this 81, approximately 33 were because of direct medical costs, so having to pay for their surgery, for their hospital admission, for their medications. And then 48 million was from non-direct medical costs. So this could have been transportation, or having to pay for food, or like traveling to the city to get surgical care. The fourth message from the Lancet Commission had a more of a macroeconomic approach, and they wanted to demonstrate that for countries to invest in surgical care, it's affordable, it can save lives, and it promotes economic growth. So traditionally, a lot of governments and global health entities had stayed away from surgery because it is complex and it does require a system. But so on the modeling they did, they estimated that to scale up surgical care to address the burden of surgical disease in low and middle income countries up to all the way to 2030, $350 billion were needed, which sounds like a very large amount, but the cost of not acting. So if instead they didn't invest in surgical care and all these people die in pregnancy or in car accidents, or kids that can't go to school and live productive lives because of a clubfoot or a cleft lip, the GDP losses were even higher, about 12.3 trillion. So even from a pure economic argument, it is wise to invest in surgical care. And then unfortunately, this is a graph from the WHO from 2016. A lot of the investment has focused on infectious diseases such as HIV, TB, and malaria, which has a small proportion of deaths per year when you compare it with surgical avoidable deaths. And so here you can see that surgery, back in 2016, there was no specific funding dedicated to surgical diseases. while other diseases get much more funding. And I'm not saying those diseases don't deserve the funding, they absolutely do. We're just trying to highlight here the lack of funding for surgical care. And so the last message from the Lancet Commission was that surgery, and again, this encompasses obstetrics, anesthesia, and the entire system that surgical patients need. They're an indivisible and indispensable part of healthcare. And going back to the SDGs, so although SDG 3 of good health and well-being is the one that it's most directly related to surgery, as we talked about, it can help to address poverty. If more women are surviving childbirth, it can help address gender equality. It can help with economic growth and inequities. So again, it's not just SDG 3, but once you look into the interconnectedness of the surgical system to everything else, you can be addressing many other sustainable development goals. I'm going to move on then to the 6 indicators that were recommended by the Lancet Commission on Global Surgery, because now that they've identified the 5 key messages and they've defined how big this problem is, they wanted to propose a way to measure how a surgical system is doing. And the way to do this, they propose, is by doing 6 surgical indicators. So I'm just going to briefly discuss how each of this is defined and give some examples. So the first one is measuring 2 hours access to surgery. So the goal was that by 2030, at least 80% of the population should have 2-hour access to surgery. The 2 hours defined as the time from onset that a woman, a pregnant woman with hemorrhage has until she dies. And again, this is a very rough estimate. That time could obviously vary, but it's been a standard time that's been considered in the obstetric community for a while. And when we measure access to surgical care, we need to think about the barriers. So the first delay in seeking care is often at the community level. So it's either patients don't know that their medical condition could require surgical care. So for example, a patient with abdominal pain might not know that they have appendicitis and they need surgery. They might not have, they might seek help from traditional healers first instead of not trusting the healthcare system. They might not have the money to stop working and go and seek care. So that's where the first delay is. The second delay was defined as the delay in reaching care. So this has to do with once the patient decides to seek care, how do they get there? So a lot of this has to do with infrastructure. Are there roads available? I worked a lot in the Amazon area in Brazil, where a lot of the transportation is by river. And so a lot of it depends on like the weather. Can they get on a boat? Can they get on a helicopter? Is there infrastructure there? Are there ambulance systems? Are these available? Can patients afford to pay for this? So that's how we group the second delay in reaching care. And the third delay is the delay in receiving care. So it is a common story for patients to finally get to hospital and there's no anesthesiologist, or there's no sterile supplies, or there's no energy for the operating room. So it's not only about reaching there, but once the patient reaches the hospital, how long does it take to receive care? And so it's hard to measure the delay in receiving care. And so the Lancet Commission proposed to measure 3 procedures. So whether a hospital can provide a cesarean section, treatment for an open fracture, and then treatment for a laparotomy for trauma. And the reason they chose this is they did an analysis and looked at 17 surgical procedures. And they found that if a health facility can provide these 3 bellwether procedures, then they have the capacity to provide the other 17. So that's where the 2-hour access to surgery comes into place. This is just a brief example. This is a GIS study that we did in the United States, looking at access to C-section. And so we used the 2-hour indicator recommended by the World Health Organization. And in North America, for access to C-section, we often use a 30-minute mark as well. And so we mapped access to obstetrical hospitals in the US. And depending on which threshold you see, you can still see that even for the high specialized level of care, anywhere between 80% if you're using this marker to 10% of the population in the United States don't have access to timely obstetrical care. So again, this was an example of how these indicators are not useful just in low and middle income countries, but can also be useful to highlight inequities in high income countries. Moving on to the second indicator is surgical workforce. So you need surgical workforce to provide care. And so the Lancet Commission estimated that anywhere between 20 to 40 surgical providers per 100,000 population are needed. And the way they calculated is they found an association between maternal mortality and the number of surgeons, anesthesiologists, and obstetricians per capita. And they found that for every 10 unit increase in providers, there was a 13% decrease in maternal mortality ratio. So again, it's just an association. It's obviously not causation, but this is what was used to determine that the ideal number is anywhere between 20 to 40 surgeons, anesthesiologists, and obstetricians. And to put this into context, in Canada, we often complain about shortages of surgeons. Canada has about 35.6 surgeons, anesthesiologists, and obstetricians per capita, which is much less than countries like US and Australia and the UK. However, when you compare it with places like Guatemala, the Democratic Republic of Congo, Ethiopia, there is a huge lack of surgical providers. And as you all know, it takes years to train these health providers. So it's definitely a priority in the global surgery community to train the surgical workforce. The third target was to measure surgical procedures. And it was estimated that to address the global burden of surgical disease, approximately 5,000 surgical procedures are needed. So this is a map of the number of procedures done per population. However, we know this is like a very broad indicator and you always need to navigate into details. So again, I work in Brazil, and for example, in Brazil, right now it looks like they're meeting the target. However, we've looked at studies looking at each of the different states and the regions, and there's massive discrepancies between the number of surgical volume in cities like Rio and Sao Paulo compared with that in rural areas like the Amazon. As well with surgical procedures, I'm not sure if the audience here is familiar with the epidemic of cesarean sections, but there's a lot of unnecessary, non-indicated cesarean sections being done. A lot of this are in places like Brazil. So again, just because you're doing more surgical procedures doesn't necessarily mean that it is the right procedure. And I'll talk a little bit more about that in a sec. I'm going to talk about these next two indicators together because they're both relate to financial risk protection. So I think when we talk about this, it's important to keep in mind that 50% of the world lives on less than $2.50 per day, and that 80% of the world lives on less than $10 per day. So I think this is important because, I mean, in Canada, we don't have to pay for surgery, but if you think about it, surgery can be very expensive. And so the Lancet Commission recommends that any surgical system that it's of high quality should take into account these expenses. So an impoverishing expense is defined as a healthcare expense that pushes a household into poverty. And it's different whether you think about poverty or extreme poverty. And a catastrophic expense is a healthcare expense that leads to a household to spend more than 40% of its non-subsistence expenditure. And again, this is particularly important for surgery because surgery is often time critical. If there is a fracture after an accident, you only have a limited window of time to do that. Same thing if a woman's in labor and they need a C-section, there's a limited time frame to get that surgery done. It's often unpredictable, so a lot of poor families haven't had the time to save money for an operation. User fees at a lot of hospitals are often high because it is often seen as a specialized care. And again, these maps are just to show you again where most of the impoverishing expenses and most of the catastrophic expenses are. The countries in white is because we didn't have the data, but we know, for example, places like the United States, even though it's a high income country, has very high rates of impoverishing and catastrophic expenses. The last target that I'm going to talk about is perioperative mortality. So perioperative mortality is death following a surgical procedure. It's often been claimed as being one of the best markers of quality of both surgery and anesthesia. There's a lot of controversy around how it should be defined exactly. And a lot of hospitals and countries do not have data on perioperative mortality. But this was a study from 2019 from the Lancet that showed that actually post-operative deaths is the third cause of death per year globally after ischemic heart disease and stroke. So again, we rarely talk about postoperative deaths as a big global health problem, but it definitely is, and it has to do with the safety of both anesthesia and surgery. So there was study in 2019, it looked at 17 countries in sub-Saharan Africa, and it was a prospective 7-day study, and they looked at mortality after cesarean sections. And they found that maternal mortality after a cesarean section in sub-Saharan Africa was 50 times higher than that of the mortality of the UK. So again, cesarean sections are a fairly straightforward surgical procedure that most surgical providers and definitely obstetricians know how to do. So it is surprising that the mortality is that much higher. When they looked at what were the causes were related to bleeding before birth as well as during the surgery, and as well anesthesia complication had one of the highest odds ratio. So again, it highlights the dire need for anesthesia care worldwide. So again, to summarize, these are the 6 indicators, and in bold are the targets for 2030. Some of them, such as preoperative mortality, the target is just to start measuring because we have no idea how most healthcare systems perform in terms of preoperative mortality. And now that I've talked mostly about access to surgical care, I want to focus a little bit more on quality, as this is what my research focuses on. So we know that access to care is not sufficient to improve outcomes. So this is an interesting study in which countries that have similar access to health facilities, and they're grouped into low income, low middle, and upper middle income countries. And then we looked at the maternal mortality in the y-axis. And we see that even though women in these countries have very similar access to care, there is a huge variation in maternal mortality. And so that's what tells us that access is not sufficient. If the facilities are not providing high quality care, the mortality is not going to improve. And then as part of this similar study, they looked at maternal death in 4 countries in sub-Saharan Africa. And they found that only 45% of the deaths were related to non-utilization. So women didn't make it to hospital, or they did not seek care, or no care was provided. But 55%, so more than half, actually made it and received care. It was just that the care was poor quality, and that's why they didn't survive. So again, although I've been talking a lot about access, I want to start shifting gears a bit more towards quality. 2018 was an exciting year for thinking about high quality health systems. These 3 publications from the World Bank, the National Academy of Science, and then the Lancet Global Health, focusing on how to measure quality, were published. And just to summarize, a few of the conclusions, or like the major points, were that poor quality of care is common across countries. It's everywhere, it's not just in low and middle income, but it is often the most vulnerable populations that suffer the consequences of poor quality care. It was estimated that high quality health systems could save over 8 million lives every year in low and middle income countries. And it was recommended that health systems should measure and report what matters most to people. So unfortunately, we've gotten used to reporting things that we think as researchers or clinicians are important. So an example for that is, for example, length of stay or intraoperative time. We often measure how much time do we spend in the operating room. Patients don't care about that. They're asleep and they just frankly don't care. They often care about how was their postoperative pain, how was their experience in the recovery room, that type of things. So this was also a call of action to start measuring patient-reported outcomes and asking patients what really matters to them. Again, all of these publications highlight there's a big gap, and research is needed in order to inform how to build high-quality health systems. And then also they highlight that improving quality of care will require a system-wide action. It cannot be a siloed intervention. High-quality health systems are defined in many different ways. When I think of obstetrical care, I like to think of the right care tailored to the local burden of illness, received by the right woman at the right time in a respectful manner. And so I think what this reflects is what the Institute of Medicine has defined as their quality framework. So they look at the 6 components of effectiveness, equitable, efficient, safe, timely, and patient-centered. And so what I want to do now is I want to walk you through this framework of the Institute of Medicine and how it relates to cesarean sections. So this is some of the work we did with many members, and this picture only shows a couple of us, to develop, it was part of a technical consultation on how to define and how to improve cesarean section safety and quality in low resource settings. And so I'm just going to go through each of these components and give you some examples on what they are and like how to measure it. So equitable care is care that does not vary in quality because of personal characteristics. So this is a graph looking at cesarean sections and by year and then split by continent. So as you can see, cesarean sections are going up everywhere, which you would think it's a good thing in terms of more access to care. But we also know that there's an epidemic of C-sections, and way too many C-sections that are not indicated are being performed. So a lot of women are being exposed to all the risk of surgeries without a reason. So there is no reason why in Latin America, the C-section rate has to be 45%, while in sub-Saharan Africa, it's about 4%. So again, access to C-sections is not equitable at all. And even when you look within countries, so this is a study that took all these countries and then looked at the C-section rates. And there's debate about what the ideal C-section rate, but it's believed to be anywhere between 10 to 15%. So that's this blue bar. And then in each of these countries, they split the population by wealth quintiles. And then as you can see, pretty much everywhere, if you are richer, you are much more likely to get a C-section than if you're poorer. And like I said, the ideal is this blue, so neither one is good. Neither the rich women are getting good care and neither are the poor women. So most countries are not providing equitable care in terms of C-sections. In terms of effectiveness, so it's providing services based on scientific knowledge to those who could benefit and not providing it to those who will not benefit. So again, going back to the C-sections and the Robson classification, obstetricians are very familiar with it. It's a system that classifies deliveries. And the idea of developing this by the WHO was to standardize comparisons of data, because not all C-sections are the same. And so the purpose of this was to identify subpopulations to then address different C-section rates. And you don't need to worry about the details, but for example, there was a study in Tanzania. So Tanzania has a low C-section rate, 6%, so below that 10 to 15% recommendation. So they're not providing enough C-sections, but even when they looked at the indications, 26% did not have an appropriate indication. And for 40% of them, it wasn't really clear why the C-section is done. So it's not effective care if you're not only not providing enough, but you're not providing it for the right reasons. In terms of efficiency, so this is about avoiding waste. And this is a study from the WHO from 2010. So like I mentioned, by 2010, they already knew that there were a lot of unnecessary C-sections being performed per year. And so they did an interesting modeling study in which they estimated what was, if we were to take all those excess C-section and calculate the cost of it, it was 2.3 billion. So it's 2.3 billion of dollars that are being wasted in unnecessary C-sections. And when you look at how much it would cost to provide C-sections to the women that need it or are not getting it, and the cost is 432 million. And again, it's obviously not as easy as taking it from those that don't need it to those who do, but it's just from a money point of view to know that it is not an excuse. Cost is not an excuse why we're not providing it. It has to do with implementation of health systems. Finally, timely care. So we know that reducing waits and harmful delays, it's a part of high quality care. So some of you might be familiar with obstetric fistulas. These usually, the most common reason these happen, but not the only reason, is from obstructed labor. So when a woman is in labor for way too long and doesn't have access to C-section. And in a very large study looking at fistulas in 9 countries in Africa, 52% ended up having a C-section. So 52% of them did have access to surgical care. However, the access was way too late. And so that's why they ended up developing the fistula, and 80% had a stillbirth. So really it was like, not only they ended up with a fistula, but also with a stillbirth. And again, we know that the maternal and neonatal mortality is much higher when you do an emergency C-section than an elective C-section. But obviously, in order to be able to provide elective C-sections, you need to be able to provide the care timely and not wait until it's an emergency. In terms of safety, so safety is defined as avoiding harm to patients from care that is intended to help. So again, going back to fistulas, so like I mentioned earlier, fistulas could be from obstructed labor, or non-obstetrical fistulas are often iatrogenic, so either caused by providers because of low quality surgery, or from other reasons such as sexual assault, from radiation, from cancer, or congenital. But as you can see here, this is a study from DRC where they do see a large number of fistulas, and 80% of fistulas that were non-obstetrical were actually related to surgical procedures. So they were iatrogenic. And when they broke them up by procedures, they found that 77% were happening after C-sections. So again, these are women that are doing the right things by seeking medical care, but then once they receive medical care, it is such low quality that they end up with fistulas. In terms of patient-centeredness, so again, this is about providing respectful care that is focused on the patient. So a study by the WHO showed that many women experience mistreatment during childbirth. This happens mostly 15 minutes before birth, which I think it's the most stressful point for both the mother and the healthcare providers. But globally, about 1/3 of women who request pain relief does not receive it. And there's a large number of unconsented procedures. So many cesarean sections are not properly consented. Episiotomy, so making a cut in the perineum, is often not consented. And many women are being checked having a vaginal exam, which is an invasive exam, without a consent. And getting back to the financials, in this study, 5% of babies were not handed over to their parents until they paid their bills. So you can imagine the stress of not having your newborn because you can't afford to pay your hospital fees. So that was just an example using C-sections on how we go about measuring surgical care. And I want to talk very briefly before I finish about one of our research projects in the Amazonas, because as you can imagine, it is quite challenging to measure surgical care in low resource settings. If you've been to hospitals in low resource settings, you can imagine some of the challenges in terms of infrastructure, resources, healthcare professionals, and so all of that contributes to low quality care. And so even in North America, we often struggle to measure surgical quality, and these are some of the tools that surgical researchers are familiar with. The problem with all of these tools is that many of them are retrospective. So you look back and then you realize how your quality was last year, not currently. Many of them rely on electronic medical records that are not widely available in many low resource areas. Many of them require prolonged follow-up. So with surgery, often in North America, we report 6-month outcomes, 1-year outcomes. And many of them are resource intensive. We have entire nurses dedicated at tracking this data. And so we know that's not feasible in a setting where you don't have enough personnel. So since these were not appropriate to low resource settings, we sat together with the team to develop a better tool. So what we did is we combined the Donabedian framework, which many of you might be familiar. So that's the one that looks at structures, processes, and outcomes. And we know that outcomes really are the most important, but you can't have the outcomes without the process and the structures. And then the 6 Institute of Medicine components that I just described in detail. And what we did is we combined them. And once we had this matrix, we did a search for what are some surgical indicators that could fit within these categories. And so this is what we came up with, which is a list of 14 evidence-based indicators of quality. And they can just be classified. So structure is least important, followed by process, and then outcomes are the most important ones. And then we can measure anywhere from safety to equitable. We couldn't find an indicator that fit everywhere, but this was a good starting point. And then the nice thing about it is that actually 6 of these indicators are the same indicators recommended by the Lancet Commission. So again, this is useful because we are still working within the framework, within the global framework to measure access to surgical care. We also knew this had to include minimal burden to the existing system. So most hospitals already have an administrative data with the data we needed. Pretty much every operating room has some sort of logbook where some of the data could be extracted. And most, I would say a very large portion of operating rooms have an operative safety checklist. So a lot of the information could be gathered from there. And the only extra thing that we added was a patient discharge survey. That's where we could gather information mostly on what happened outside the hospital, so travel time, as well as expenditures data. And so we did it. In this publication, we talk about some of the challenges. This is the results from one of the hospitals in the Amazonas. And so the green are the only two indicators where they are meeting the targets for quality, while in red, they are not. So even though they had no idea what their quality of surgical care was, this allowed them to realize and choose which areas they wanted to focus on. So based on this, they actually led a lot of quality improvement initiatives to focus on whichever areas they felt they needed to. And by collecting data and organizing it in this matrix, they collect data monthly, and then they're able to track their progress. So this was our team from the University of Amazonas, nurses and medical students that did most of the data collection. So we showed that it is feasible to adapt this tool to a local context and to engage providers without adding much extra significant burden. And like I mentioned, these results are being used monthly to guide quality improvement initiatives. And then as far as we're aware, this tool is also being implemented in rural Mexico and Chiapas, as well as the College of Surgeons in Manila and the Philippines. They've actually, it's really cool, they turn it into an app, and they are implementing it in a bunch of hospitals to, again, start measuring quality, because unless you measure, you're not going to really know how to improve it or whether or not you're improving it. So with that, I'll just wrap this presentation up. So hopefully by now you realize that global surgery is a broad field. It combines not only clinical care, but also research, policy, and advocacy. And the goal is to ensure universal access to surgical care. And by surgical care, we mean obviously obstetric and anesthesia care. So the Lancet Commission on Global Surgery laid the foundation for more like research and academic way to measure surgical systems using the 6 surgical indicators. These 6 indicators have since then been endorsed by the World Bank as some of the 100 health core indicators. So a lot of countries are starting to collect them at the hospital level, and then at the regional level and the national level. In terms of maternal mortality, despite significant progress, mostly because of increase to facilities, maternal mortality still remains high. And we think part of this has to do lack of access to high quality care and also lack of access to surgery. A lot of women are getting good care in terms of vaginal deliveries, but they're not getting good care in terms of cesarean sections. And although it is challenging, we have demonstrated that it is feasible and essential to measure quality of surgical care, particularly in low resource settings. So with that, I'm happy to answer any questions, or if there's anything else that needs clarification, or if anybody wants to email me, you're welcome to.